Esotropia with V pattern increases in downward gaze and decreases in upward gaze. Exotropia with V pattern increases in upward gaze and decreases in downward gaze. Esotropia with A pattern increases in upward gaze and decreases in downward gaze. Exotropia with A pattern increases in downward gaze and decreases in upward gaze. Ex-patent strabismus describe patients who may have essentially no deviation or only a small one in primary position, although exotropia is present in upward and downward gaze. Y-pattern strabismus describe patients who may have exotropia only in upward gaze. Lambda pattern strabismus describe patients who may have exotropia only in downward gaze. When the difference in deviation between upward and downward gaze is 15 degrees or more, a V pattern should be considered as significant vertical incompetence. In V pattern esotropia with elevation in adduction and inferior oblique weakening procedure merely closes the V pattern in upward gaze, and horizontal surgery is done for esotropia as usual. In V pattern esotropia without elevation in adduction, horizontal muscle surgery are done to correct the esotropia as usual, with downward transposition of the medial rectus muscles and upward transposition of the lateral rectus muscles. In V pattern exotropia with elevation in adduction, a weakening procedure on the inferior oblique muscles will decrease the deviation in upward gaze. However, if clinically significant amounts of exodeviation in primary and downward positions of gaze are present, myectomy of the inferior obliques must be combined with horizontal surgery. In V pattern exotropia without elevation in adduction, a horizontal surgery and, if the deviation is of significant magnitude and downward gaze, downward transposition of the medial rectus muscle and upward transposition of the lateral rectus muscle are indicated. In A pattern esotropia with depression in adduction, a bilateral tenectomy or recession of the superior oblique tendon is required. To counteract the predictable increase of the esotropia in downward gaze following superior oblique weakening, it is usual to be combined with horizontal surgery. In A pattern esotropia without depression in adduction, it is necessary to combine recession of the medial rectus muscle and resection of the lateral rectus muscle with upward transposition of the medial rectus and downward transposition of the lateral rectus muscle. In A pattern exotropia with depression in adduction, tenectomy of both superior oblique tendons will lead to a predictable decrease of the deviation in downward gaze. If only a small exodeviation in primary position and upward gaze is present, this procedure may be sufficient. Otherwise, horizontal surgery must also be performed. In A pattern exotropia without depression in adduction, a horizontal surgery with upward transposition of the medial rectus muscle and downward transposition of the lateral rectus muscle must be performed. In Y pattern exotropia with elevation in adduction, a bilateral weakening of the inferior oblique muscles will close the Y pattern in upward gaze and must be combined with an operation on the horizontal rectus muscles to correct the exotropia. In Y pattern exotropia without elevation in adduction, no treatment is necessary when the patient fuses in primary position and downward gaze, has a normal head posture, and does not complain about double vision in upward gaze. When chin elevation is present, surgical weakening of both inferior oblique muscles will close the Y pattern. In lambda pattern exotropia with depression in adduction, patients with a lambda pattern will usually depress the chin to maintain fusion in primary position and upward gaze and to avoid the downward gaze position. A weakening of both superior oblique muscles will close the lambda pattern.